Okay, welcome everybody. This is Chapter 6, dealing with the muscular system. So, muscle tissue is one of the four primary tissue types. It's specialized for contraction. There are three types of muscle tissue: skeletal, cardiac, and smooth muscle tissue. And they're pictured in diagram over here to the right. And you notice right away that they look different in the cartoon. They also look different under the microscope. They're found in different places, and they have different methods of control. Skeletal muscle moves the body by pulling on the bones of the skeleton, while cardiac muscle is found exclusively in the heart to propel blood, and smooth muscle moves fluid and solids along the digestive tract, regulates the diameter of blood vessels, has some role in the movement of lymph, is connected to every hair in your body and responsible for the production of goosebumps, is also found in the iris of your eye, where it helps to control the diameter of the pupil. Skeletal muscle produces skeletal movement. Muscle contractions pull on tendons and move the bones of the skeleton. It also helps maintain body posture and position. The constant muscle activity maintains tension in the muscle and keeps us upright, keeps us balanced. It also supports soft tissue. There are layers of skeletal muscle that form the abdominal wall and the floor of the pelvic cavity that protect the internal organs located there. It also supports the weight of visceral organs and protects the internal tissues. It also guards entrances and exits to the body in the form of what we call sphincters. Skeletal muscle encircle openings to digestive and urinary tracts, and they also provide voluntary control over swallowing, defecation, and urination. It also helps to maintain body temperature through shivering thermogenesis, where we convert chemical potential energy into the energy of heat by hydrolyzing ATP. It also provides a nutrient reserve. Contractile protein in the skeletal muscle is broken down into amino acid when the intake of protein or calories in the diet is not adequate to meet needs. Now, this is an unusual situation. We generally see this in individuals that deliberately have low protein content in their diet or are in starvation. The amino acids are used to synthesize glucose and to provide energy. And it's sort of an emergency way to keep the body going until protein's reintroduced into the diet. So skeletal muscle is a bundle of skeletal muscle fibers that's wrapped in connective tissue layers. The epimysium is a dense layer of collagen fibers that surround the entire muscle, while the perimysium is a fibrous layer that divides the skeletal muscle into bundles of fascicles, and the endomysium is delicate connective tissue that surrounds individual muscle fibers. Tendons are collagen fibers of connective tissue that exist in layers in skeletal muscle and extend beyond the muscle at its end. A bundle of fibers is a tendon, which can attach the muscle to the bone. A sheet of fibers is termed an aponeurosis, which can attach the muscle to a broader area of the body. And the collagen fibers for each of these extend into the bone matrix as those Sharpie's fibers that we learned about in the last chapter. You might say, well, okay, where would I find an aponeurosis? I kind of know what where a tendon would be found. Aponeurosis, an example, would be across the scalp. It connects the muscle of the forehead, called the frontalis muscle, to the muscle that's on the back of the skull, called the occipitalis. That's one example. And there's also an abdominal aponeurosis, into which the powerful abdominal muscles on the lateral aspect of the abdomen insert. Those are the internal and external obliques. So those are just a couple of examples. A muscle cell is a muscle fiber. The cell membrane is termed the sarcolemma, while the cytoplasm is the sarcoplasm, and the ER is the sarcoplasmic reticulum. So the prefix sarco means of or pertaining to muscle. Note that skeletal muscle is unusual in that it contains hundreds of nuclei filled with cylindrical myofibrils which are packed with myofilaments, which are composed of actin and myosin. The thin filaments are the actin and the thick are the myosin. The banded appearance of the myofibrils gives the entire fiber a striated appearance, and these striations are significant because they represent areas of overlap between actin and myosin. So that's their import. As those areas of overlap increase, the actin and myosin overlap each other to a greater extent under the influence of ATP and a phenomenon called cross-bridging. The myofibrils shorten, and that shortens the myofibers, and that in turn can shorten the entire muscle, and that's what produces force. The fact that they're multinucleate is an unusual situation. There's only a few multinucleate muscles or multinucleate cells in the body. Skeletal muscle is one example. Osteoclasts are another. What happens when these cells are formed is that they group together, and as they cluster, they lose their intervening cell membranes and fuse and become what we call a syncytia. Okay, so this is kind of an unusual word here. Syncytia. Let's do this in blue. Okay, and that's just a term for a multinucleate cell. In cells like osteoclast or muscle, that's a normal state. It can also indicate disease states. For instance, there are certain viruses that are cancer-causing that produce syncytia as a hallmark of their infection process. So it's an unusual situation. Why does this happen? Because the muscle cell is suited to its task of producing force. As a very long cell with a lot of overlap in its protein, it has the potential to generate more power than if it were a bunch of individual cells. So take a listen to muscle contraction. These are the events that happen at the gap between a motor neuron and a muscle cell that lead ultimately to contraction.
Nerve impulses, also known as action potentials, travel from the brain or spinal cord to trigger the contraction of skeletal muscles. An action potential propagates down a motor neuron to a skeletal muscle fiber. The site where a motor neuron excites a skeletal muscle fiber is called the neuromuscular junction. This junction is a chemical synapse consisting of the points of contact between the axon terminals of a motor neuron and the motor end plate of a skeletal muscle fiber. The events at the neuromuscular junction occur in 7 coordinated steps. Step 1. An action potential travels the length of the axon of a motor neuron to an axon terminal. Step 2. Voltage-gated calcium channels open and calcium ions diffuse into the terminal. Step 3. Calcium entry causes synaptic vesicles to release acetylcholine via exocytosis. Step 4. Acetylcholine diffuses across the synaptic cleft and binds to acetylcholine receptors, which contain ligand-gated cation channels. Step 5. These ligand-gated cation channels open. Step 6. Sodium ions, shown here in red, enter the muscle fiber, and potassium ions, shown here in blue, exit the muscle fiber. The greater inward flux of sodium ions relative to the outward flux of potassium ions causes the membrane potential to become less negative. Step 7. Once the membrane potential reaches a threshold value, an action potential propagates along the sarcolemma. Neural transmission to a muscle fiber ceases when acetylcholine is removed from the synaptic cleft. This removal occurs in two ways. 1. Acetylcholine diffuses away from the synapse. 2. Acetylcholine is broken down by the enzyme acetylcholinesterase to acetic acid and choline. Choline is then transported into the axon terminal for the resynthesis of acetylcholine.
Take a listen to excitation-contraction coupling.
Typically, a single motor neuron arising in the brain or spinal cord conducts action potentials that travel to hundreds of skeletal muscle fibers within a muscle. The sequence of events that converts action potentials in a muscle fiber to a contraction is known as excitation-contraction coupling. If we look at a single muscle fiber, we see that an action potential travels across the entire sarcolemma and is rapidly conducted into the interior of the muscle fiber by structures called transverse tubules. Transverse, or T-tubules, are regularly spaced enfoldings of the sarcolemma that branch extensively throughout the muscle fiber. At numerous junctions, the T-tubules make contact with a calcium-storing membranous network known as a sarcoplasmic reticulum, or SR. Where it abuts the T-tubule, the SR forms sac-like bulges called terminal cisternae. One portion of a T-tubule plus two adjacent terminal cisternae is known as a triad. The membranes of the T-tubule and terminal cisternae are linked by a series of proteins that control calcium release. As an action potential travels down the T-tubule, it causes a voltage-sensitive protein to change shape. This shape change opens a calcium release channel in the SR, allowing calcium ions to flood the sarcoplasm. This rapid influx of calcium triggers a contraction of the skeletal muscle fiber. Thus, calcium ions are responsible for the coupling of excitation to the contraction of skeletal muscle fibers.
These are the events that happen inside the muscle cell that promote contraction. And finally, the cross-bridging cycle, which is essentially the interaction of actin and myosin along with the production of kinetic energy that actually shortens the myofibrils.
The contraction of a skeletal muscle generates the force necessary to move the skeleton. A contraction is triggered by a series of molecular events known as the cross-bridge cycle. In a skeletal muscle fiber, the functional unit of contraction is called the sarcomere. A sarcomere shortens when myosin heads in thick myofilaments form cross bridges with actin molecules in thin myofilaments. The formation of a cross bridge is initiated when calcium ions, released from the sarcoplasmic reticulum, bind to troponin. This binding causes troponin to change shape. Tropomyosin moves away from the myosin-binding sites on actin, allowing the myosin head to bind actin and form a cross bridge. Also note that the myosin head must be activated before a cross-bridge cycle can begin. This occurs when ATP binds to the myosin head and is hydrolyzed to ADP and inorganic phosphate. The energy liberated from the hydrolysis of ATP activates the myosin head, forcing it into the cocked position. A cross-bridge cycle may be divided into 4 steps. Step 1. Cross-bridge formation. The activated myosin head binds to actin, forming a cross-bridge. Inorganic phosphate is released, and the bond between myosin and actin becomes stronger. Step 2. The power stroke. ADP is released and the activated myosin head pivots, sliding the thin myofilament toward the center of the sarcomere. Step 3. Cross-bridge detachment. When another ATP binds to the myosin head, the link between the myosin head and actin weakens, and the myosin head detaches. Step 4. Reactivation of the myosin head. ATP is hydrolyzed to ADP and inorganic phosphate. The energy released during hydrolysis reactivates the myosin head, returning it to the cocked position. As long as the binding sites on actin remain exposed, the cross-bridge cycle will repeat. And as the cycle repeats, the thin myofilaments are pulled toward each other and the sarcomere shortens. This shortening causes the whole muscle to contract. Cross-bridge cycling ends when calcium ions are actively transported back into the sarcoplasmic reticulum. Troponin returns to its original shape, allowing tropomyosin to glide over and cover the myosin-binding site on actin.
Muscle fibers are made up of units that respond to innervation called motor units, and that's a skeletal muscle fiber and the motor neurons that talk to it. Okay, so the idea here is that you have gangs of these muscle fibers that get commands from different motor neurons. The size of the motor unit indicates how precise the movement is going to be. The smaller the motor unit, the more precise the movement. The larger the motor unit, the more gross the movement is going to be. And the reason for that, again, is if you're stimulating a bunch of muscle cells at the same time, you're not going to be capable of fine controlled movement. You're going to have big movements. Examples would be motor units that are responsible for things like walking, okay? Whereas where you would find these smaller motor units would be in places like your hands and your face. Motor fibers of different motor units are intermingled in the tissue of the muscle. Recruitment is where smaller units are activated initially to produce a small amount of force, followed by larger, more powerful motor units that increase the tension. And so the idea here is that we slowly increase the amount of force possible in the muscle by recruiting more and more motor units until we get to maximum tension production. Now, some motor units are active even when the muscle's not actively contracting, and the purpose is to remind the muscle that it is contractile tissue so that it continues to make actin and myosin, which are the mechanism whereby muscle is able to shorten. Activation tenses and firms the muscle. The resting tension is called muscle tone. And there are subconscious processes that change which motor units are active, maintaining constant tension, yet letting individual fibers relax. So we have a cycling of muscle tone through different motor units, much the same way that we get a cycling of motor units when the muscle goes into incomplete tetanus. And this is again to conserve energy so that the muscle can continue to function without exhausting its nutrient stores. In isotonic contraction, the tension is produced greater than the load on the muscle, and the result is that the muscle can shorten. The tension rises until it exceeds the load. When the muscle shortens, the tension remains constant, and this is why we call it isotonic. So here you can see where the contraction initiates. Here's the peak tension, and then the muscle relaxes. This is what most of us think about when we think about a muscle contracting, is the muscle in fact changing its dimensions. But that's not the only type of muscle contraction that muscle's capable of. There's isometric contraction, in which tension is generated but the muscle length stays the same. Individual muscle fibers will shorten and the connective tissue will stretch, but the tension does not exceed the load, and the result then is that the load does not move. Okay, so you might say, okay, well, give me an example of an isometric contraction. If you were to push on a solid wall, okay, you would generate tension, but you wouldn't be capable of moving the object. The result is that to a great extent, the whole muscle isn't going to shorten very much, but you'll still use energy, you'll still create tension, and you'll still build muscle strength. And so there was a whole series of exercises that was initiated and sold by a man named Charles Atlas back in the 40s and 50s, called dynamic tension. And he got this idea of a series of isometric exercises by watching jungle cats in the zoo. He found that even though they were in very small cages, they managed to maintain their muscle tone primarily through a series of isometric contractions. If you want an example, for one of his exercises, he would tell you to clasp your two hands together in front of your chest and then try to pull them apart as hard as possible. And then you can feel the tension developing, but the muscle isn't going to shorten to any significant extent. Now, where does the muscle get its fuel? At rest, mitochondria produce a surplus of ATP from fatty acids and glucose. ATP is used to form creatine phosphate and glycogen. With moderate activity, we see an increased demand for ATP. Production is via aerobic pathways. That means oxygen is present, and we see metabolism of pyruvate in the mitochondria. The result is that the 6-carbon glucose molecule is broken down into 2 3-carbon pyruvates, and then the pyruvate molecule is further broken down into ultimately carbon dioxide and water. And we realize a significant amount of ATP, because remember that it's in the mitochondria where the bulk of ATP production happens in the cell. 32 out of the 38 ATP that are produced by oxidizing sugar happen as a result of the Krebs cycle and the electron transport chain in the mitochondria. There's no fatigue until glycogen, lipid, and amino acid reserves are exhausted. And this generally doesn't take place at rest because the circulatory system can keep up with the resting muscle demands for energy. It delivers enough oxygen and enough nutrients to keep the muscle's internal energy stores flush while allowing the muscle to generate ATP to fuel contraction. You have to remember that in skeletal muscle, there are two sources of energy, in a sense. There are glycogen granules, which are sugar polymers that the muscle keeps inside the cytoplasm for use as quick energy. And also there's myoglobin, which is an oxygen-binding protein that provides oxygen to the muscle in the event that the circulatory system can't deliver oxygen to the muscle tissue for brief periods. And so most of the time the muscle's able to keep up with its demands. Now at peak activity, the mitochondria are producing ATP at a maximum rate. Only a third of the needed ATP is produced by aerobic means. The remaining 2/3 of ATP are produced anaerobically via the reactions of glycolysis, which happens again in the cytoplasm of the cell. Glucose is converted to pyruvate, which is converted into lactic acid, which dissociates into lactate and protons, which lowers the pH of the muscle cell. This causes a change in enzyme activity and prevents the muscle fiber eventually from contracting and ultimately results in fatigue. And so you often hear people talk about feeling the burn or the buildup of lactic acid in the muscle that exhausts them. This is what happens from training at peak levels for extended periods. In recovery, the liver and the muscle work together in order to replenish fuel stores and energy for the muscle. The Cori cycle involves lactate transport to the liver via the bloodstream, where it is converted back into pyruvate, and then the pyruvate is broken down in the mitochondria for energy. That's about 30% happening in the liver. The remaining 70% is transported back to the muscle in the form of glucose, which is eventually going to find its way to the muscle. The muscle will then use the glucose to restore its glycogen reserves and will also use a fair portion of it to generate energy. The amount of oxygen required to restore these conditions is what's called the oxygen debt. It's one of the reasons why after strenuous exercising you hyperventilate for a time. Now, skeletal muscles are almost half the weight of the body. They contain more mass than any other organ system, and they're organized into axial muscles, which support and position the axial skeleton, and appendicular muscles, which support, move, and brace the limbs. And you can see in this drawing the axial muscles primarily here, okay, and the appendicular muscles here and here. When we refer to muscle activity, gross muscle activity, we have to familiarize ourselves with three components of the muscle as a descriptor: the origin and the insertion and the action. The origin is defined where the fixed end of the skeletal muscle attaches. The insertion is where the movable end of the skeletal muscle attaches, and the action is the specific movement of that particular skeletal muscle. So what we're looking at here is an example of movement at the elbow, flexion and extension. The agonist, or the prime mover, is responsible for generating the particular movement. The example shown below is the biceps brachii acting and bending the elbow, while the synergist helps the agonist work effectively by providing additional pull or stability. Example here would be the brachioradialis, which assists in bending the elbow, as does the brachialis. And the antagonist opposes the action of the agonist. The example here would be the triceps brachii in bending the elbow. Okay, so let's illustrate where each of these are. Okay, so the agonist here, the biceps brachii, is this muscle. And you can see the attachment points, right? We attach to the scapula, and we also attach across the elbow joint to the radius. Okay? The synergist helps. The brachioradialis is an example of the synergist, and you can see the brachioradialis here. So he attaches to the radius, and he also attaches to the humerus across the elbow. And then the antagonist, the triceps brachii, is shown over here. And you can see here his attachment to the olecranon, the point of your elbow, across the elbow joint on the opposite side of the humerus, and also up here near the scapula. Okay, so he opposes the action. Now, note something about the names too. Okay, brachii comes up, or brachial, in every single one of these muscles. What's the brachial region? It's the upper arm. Okay. Other descriptors. Okay. Biceps brachii. Biceps means two heads. So the biceps brachii is a two-headed muscle in the upper arm region. The brachioradialis. Well, radialis is just telling you another attachment point. So this attaches to the radius. That's where he actually inserts. And he comes down out of the brachial region from the distal humerus, crossing the elbow. And then here, the triceps brachii is a three-headed muscle on the back side of the arm, and he allows you to extend the forearm. Okay, so when we name muscles, we include clues about their function or their shape or their size or their direction of fibers in the names, in many of the names. So we can name them according to the region of the body in which they're found, their position, the nature of their origin, their overall shape, their overall size, or the actions that they perform. And this list is going to show you some of the terms indicating specific regions in the body, and then types of terms indicating direction or fascicle organization of the muscle, and also terms indicating the structural characteristics of the muscle, and terms indicating their actions. So this is a good chart to kind of give you lay of the land with regard to muscle names, and use this as a way to try and figure out where a muscle is located and what a muscle might be doing. Okay? Hello. Flexion and extension are some of the fundamental movements that muscles are capable of producing. And again, all these movements are relative to anatomical position, which is you standing facing forward with your palms facing forward, your arms at your sides, and your feet flat on the ground. It's applied to the movement of long bones and limbs and to the movements of the axial skeleton. Flexion is a movement that reduces the angle between two structures from anatomical position, while extension increases the angle between two structures, and hyperextension is extension beyond anatomical position. So to demonstrate, here is a look at, first you'll see flexion, and then you'll see extension of the forearm. Okay. Now remember, we're talking about anatomical position. This is a lateral view of somebody in anatomical position. You can see here that when we're talking about flexion, okay, we're talking about decreasing the angle between the plane that passes through the body in a coronal or frontal section and the limb or the extension being moved. Okay, so if we want to diagram this so that it makes it a little bit more clear, flexion is what is shown when the arm moves, forearm moves up. Okay, extension would be the opposite direction. So I'm going to draw in all arrows having to do with flexion. Okay, that would be flexion of the thigh at the hip. Okay, that's flexion of the forearm at the elbow. Flexion of the head would be bringing your head back straight up from where it's resting on your chest. Okay, Extension is going to be the opposite, and we'll do extension in red. Okay, so extension of the forearm, the red arrow here. Extension of the thigh at the hip, the red arrow here. Extension of the head is again, extension of the head is going to be this. Okay, this flexion of the head should be the arrow pointing in the opposite direction. So let me really quick fix that. Okay, so let's fix that. That blue arrow should be flexion, and that's extension. Okay. Other terms, lateral flexion would be movement away from midline. You can see two examples of lateral flexion here. Okay. This is when the vertebral column bends to one side. Dorsiflexion is where the top of the foot is lifted. So this is flexion at the ankle joint, involving the elevation of the sole of the foot with the toes pointing upwards and the heel on the ground. While plantar flexion is extension of the ankle joint with the toes pointing downward. Okay, so here's an example of these movements. A dorsiflexion. Okay, so that first movement that you'll see is dorsiflexion, then dorsextension, okay, which is also plantar flexion. Abduction and adduction involve movement away or towards the body's midline. So these refer to movements of the appendicular skeleton. So here we're talking about movements of the arm, the forearm, the thigh, the leg, the feet, the hands, the fingers, and toes. Okay. With abduction, we have movement away from the longitudinal axis. Spreading the fingers as an example, or the toes, moves them away from midline. Adduction means bringing back towards the longitudinal axis, such as bringing the fingers or the toes together, or moving the arm or the leg back towards midline. So here's an example. You can see here abduction, adduction. Okay, that was abduction and adduction of the arm. Okay, abduction and adduction of the fingers, shown up here. Abduction and adduction of the wrist, shown here. Okay. Circumdiction is the tracing of a large circle with the hand while keeping the arm straight. You can also do this at the hip joint. If you remember the hokey pokey, right? Put your right foot in and swirl it all about. If you're standing on your left leg and you have your right foot off the floor, so you're tilted a little bit to the left, and you trace a circle with your big toe, keeping your leg straight, okay, that would also be circumdiction. It's only possible at ball and socket joints because they provide the greatest degree of movement. So you can see here an example of circumdiction. Let's take a quick look at the video. So you can see there, circumdiction. A pitcher doing a wind-up will do a circumdiction prior to throwing the ball, especially if you've ever seen a softball pitcher throw a ball underhanded. Okay. Now, rotation can be at the trunk or at the limbs. The trunk has directional rotation. We can rotate laterally or we can rotate medially. And again, this is all with reference to anatomical position. Left rotation would be looking to the left. Right rotation would be looking to the right. In the limbs, medial rotation is internal or inward rotation, where the anterior surface of the limb is turned towards the trunk, and lateral rotation is external or outward rotation, where you return basically to anatomical position. If we're referring to, for instance, the forearm, Okay, so you can see examples of these in the figure. And again, we'll use two colors. We'll use red for lateral rotation. So with lateral rotation, if you're, for instance, with the forearm, if the arm were with the palm facing backwards, lateral rotation would be in this direction, so that the palm would then be facing forward. Okay. You can also do lateral and medial rotation with the arm itself. Okay, and a way to illustrate that would be to stand in an anatomical position and then bend your elbows at a right angle, and medial rotation of the arm would end up rotating the upper arm so that the forearm was pointed closest to the midsection of your body, whereas lateral rotation, you would rotate the upper arm so that the forearm was pointing furthest away from the body. So it's a way to illustrate that. Obviously, you can also medially and laterally rotate the thigh or the leg, which we would think of as the lower leg, and medial rotation would just be back towards midline. Here you can see an example of lateral rotation to the right. This would be lateral rotation to the left. Okay, and what would medial rotation be? Well, if we pick another color here, this would be returning from looking to the right from anatomical position to having you face forward. Okay, so that would be medial rotation. If we were looking left, medial rotation would be looking forward again from having face to the left. Okay, over here with the forearm, medial rotation would be in this direction. Okay, and the palms would be facing backwards towards the back of the body. You can do the same thing with medially rotating the thigh or the leg. Okay, so medial and lateral rotation are opposite movements of each other. Rotation of the radial head, causing rolling of the distal epiphysis of the radius across the anterior surface of the ulna, is what we call pronation and supination. You could also think of this as medial and lateral rotation of the forearm. Pronation is turning the wrist and a hand from the palm facing front to the palm facing back, as shown down here in the figure, while supination is turning the wrist and hand from the palm facing back to the palm facing forward. Opposition is a special movement. This is where the thumb can be brought into contact with the tips of any of the four remaining fingers, while inversion and eversion involve twisting of the foot. Inversion is turning the sole inward, eversion being turning the sole outward. So let's take a look at first opposition. Okay, so there's opposition, and here is inversion and eversion. It's eversion, that's inversion. Okay, just to make sure that we hit everything here, I wanted to show you pronation and supination. Here, there's pronation, there's supination. Right? So, some more movements. Protraction and retraction. Protraction is moving a body part anteriorly in a horizontal plane, while retraction is moving a body part posteriorly in a horizontal plane. Depression and elevation. Depression is moving inferiorly, while elevation is moving in a superior direction. So if we were to, let's say, give you an example of protraction and retraction, we'll do this in gray. Okay, so you've got the illustration in the upper right here. We'll try to illustrate this movement so that it makes more sense to you. But anyway, if this is your mouth and your chin in anatomical position, okay, if we were to protract, the jaw would look like this. So the lower jaw sticking out. Okay, and if we were to retract, it would look more like this. With the jaw, lower jaw pulled in. Okay, so that's the mouth there. Okay, so that is retraction. Okay, we want to touch on some of the major muscles and give you their job description by providing you the origin, the insertion, and the action of the muscle. Now, as far as what you're going to need to know for the exams and for the homework, you'll need to know action, and you'll need to know the muscle name. You won't need to necessarily know the origin and insertion, but I'll provide that because it helps you understand the muscle's action. So the axial muscles make up about 60% of the skeletal muscle. They originate on the axial skeleton. They position the head in the spinal column, and they move the rib cage, and they assist in breathing. While the appendicular muscles stabilize or move parts of the appendicular skeleton. They make up 40% of the skeletal muscle. If we were to essentially trace these, let's just do that real quick. And again, this is just an approximate, but for the axial muscles, okay, we're talking about muscles that are found primarily here. Okay, and with appendicular muscles, and also posterior view, right, we can include this as well. Okay, and then with appendicular muscles, let's do this in blue. We're talking about muscles that are primarily here, 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 okay, and here and here. So we'll go through the major muscles in each of these groups. So these are the muscles of the head and neck, and we show the origin, insertion, and action. They function in eating and are useful for communication. They're also critical in facial expression. The muscles originate on the surface of the skull, and they insert onto connective tissue and the dermis of the skin, and they function in eating by moving the jaw. So what are some of the major muscles? Well, we can point out quite a few of them here. What I'll do is I'll color them in as we go along. Let's use blue. Okay, so we can start at the top, all right, and we have here the temporalis muscle. Okay, I'm tracing it for you here. I'm sorry, not the temporalis, but the frontalis muscle. And it's named for the bone of the skull that it sits in front of, which is the frontal bone. Okay, so its origin is the aponeurosis of the scalp. It inserts onto the skin of the eyebrows and the ridge of the nose, and what he allows you to do is to raise your eyebrows in a look of surprise. Okay, so that's the frontalis. So let's write raise eyebrows here. Moving down, these circular muscles around each orbit are the orbicularis oculi, and their origin is the medial margin of the orbit. They insert onto the skin around the eyelids, and they allow you to blink. Okay, close your eye or blink. All right, so that's these guys. Okay. The zygomaticus minor and major help you to smile. Okay, the zygomaticus major is this guy. The zygomaticus minor is this one. Okay, and why are they called major and minor? Because the major is longer than the minor. They insert onto the corners of the mouth, and the upper lip, and they help to retract and elevate the corner of the mouth and lip, so in a sense they help you smile. Okay, we'll write smile here. Okay, moving down, the platysma is this big flat muscle here. It's a superficial muscle. Okay, and its origin is the superior thorax between the cartilage of the second rib and the acromion of the scapula. It inserts onto the lower jaw, which is the mandible, and it also inserts onto the skin of the cheek, and it tenses the skin of the neck and helps to depress the mandible as well. Okay. Over here, the temporalis muscle, this guy here, runs from the temporal bone, and he inserts onto the mandible, and he helps you elevate the mandible and close the jaw, so he's one of the muscles that helps you chew. The masseter runs from the zygomatic bone down to the mandible, okay, and he elevates the jaw and closes the jaw, so he also helps you chew. If you want to feel these muscles in action, with your teeth clenched, put your hands on your temple and on the side of your lower jaw, and then grit your teeth, and you'll feel these muscles working. The buccinator is muscle in your cheek. The buccal region is the cheek. It's underneath the masseter. You can see a little bit of it here. Okay, and his origin is the alveolar process of the maxilla and the mandible, and he inserts onto the fibers of the orbicularis oris, which is this circular muscle around the mouth, and his action is to compress the cheeks, so he helps you suck and blow. Okay. The orbicularis oris is this circular muscle here. Okay. And he has an origin on the maxillary bones of the mandible. He inserts onto the lips. He compresses and purses the lips. Okay. And so he helps you whistle, as an example of an action. Okay. This is lateral view. Again, these muscles are important in facial expression. They originate on the surface of the skull and insert onto the connective tissue and dermis of the skin and function in moving the jaw. And you can see some muscles here in lateral view that we couldn't see in frontal view. It's just pointing out the ones that are more clearly visible now. Again, we'll do them in blue. The sternocleidomastoid is this big muscle here. Okay, he runs from the mastoid process of the temporal bone, which is that bump behind your external ear, and he inserts onto the clavicle and onto the sternum, and that's where the name comes from. Okay, and what does he do? Well, he helps you to flex the neck. If you only flex one of the sternocleidomastoids, either the left or the right, you will bend the head towards the shoulder or rotate the neck. Okay, so big muscle there. The occipitalis, this guy back here, inserts onto the aponeurosis of the scalp, and he helps to tense and retract the scalp, so he kind of works along with the frontalis when you register, for instance, an expression of surprise. An aponeurosis, in case you're wondering, is just a broad, flat tendon. Okay, these are the muscles of the deep posterior trunk and abdominal pelvic region. The muscles of the vertebral column support and align the axial skeleton, and they're arranged in several layers. They originate or insert on ribs and vertebral processes. The group as a whole extends from the sacrum to the skull. There are numerous individual muscles that have different lengths. So, again, we can start with each muscle, and we'll pick blue again. So the spinalis muscle Okay, you can see the spinalis here. Okay, the origin of the spinous and transverse processes of the thoracic and superior lumbar vertebrae. Okay, so these muscles have origins that run all the way down to the lumbar region. Okay, and they insert onto the spinous process of the superior thoracic vertebrae. Okay, so where are those? Well, the thoracic vertebrae are the ones that have ribs, so you can see these little points of insertion here. Okay, and what does he do? He extends the vertebral column. So this is sort of a trace showing you this muscle. Okay, through here. All right, the longissimus here. Okay, again, you can see these insertion points here coming down. Okay, down here. Has an origin on the transverse process of the inferior cervical, thoracic, and lumbar vertebrae. It inserts onto the mastoid process of the temporal bone and the transverse processes of the middle and superior cervical and thoracic vertebrae and the inferior surface of the ribs. And together, if they flex, the two sides extend the vertebral column alone. They'll rotate and laterally flex the column to that side. Okay, so that's the longissimus. See it sort of circled here. Okay, the iliocostalis shown here. You can see the insertions back here. Runs from the ilium to the costal ribs. Okay. Origins on the superior borders of the ribs, the iliac crest, the sacral crest, and the spinous processes of the lumbar vertebrae. So you can see down here as well. And he inserts onto the transverse process of the middle and inferior cervical vertebrae and the inferior surfaces of the inferior 7 ribs. And the action is to extend or laterally flex the vertebral column and to depress the ribs. The quadratus lumborum runs from the last floating rib up to the crest of the ilium here. See him right there. And when they flex together, they depress the ribs. If they flex one or the other, they can laterally flex the vertebral column to one side or the other. Okay, and in case you're wondering, you're looking really at two different views of the human body from the back here. This is posterior view. Okay, but what you have to remember here with this picture is that this side is the deep side, closest to the bones, and that this side over here is the superficial side, which is closest to the surface of the body. Okay, so superficial and deep. Keep that in mind. So, in case you're wondering, right, the quadratus lumborum would lie underneath the iliocostalis as well as the longissimus, as an example. Okay, here we are again looking at the oblique and rectus muscles of the walls of the trunk as well as the muscles of the thoracic region. When we see the word oblique, remember that means the muscles run at an angle to the long body axis. So the fibers are kind of tilted. Whereas if we see the word rectus, the muscles fibers run parallel to the long axis of the body, and if you see the word transversus, they run at a right angle to the long axis of the body. So again, keeping ourselves oriented, we have to remember that in this figure, the left-hand side is the deep side. So this is the deep side. Okay, and this is the superficial side. So let's start with the superficial muscles. The pectoralis major is this big guy here. Okay. See him coming around here. And he inserts onto the upper arm, and he has origins along the sternum. Okay. So he is a major arm mover. Okay. And the pectoralis minor is this guy underneath him. Okay. Again, the pectoral region is what? It's the region of the chest. Every superhero worth his salt has his logo on his pectoralis muscles. Okay. And what this guy does is he attaches now to the acromion of the scapula, and he also attaches to the costal cartilages of the true ribs. Okay, so he helps to, among other things, protract the scapula. So this is one of the muscles that you would use when you throw a baseball. Okay, so that's the pectoralis minor, right, that I just sort of illustrated for you there. We can write him in pec minor. That's abbreviated. Okay, so that's the pec minor. The external intercostals run from the inferior border of each rib and insert onto the superior border of the rib underneath it. They help to elevate the ribs, so they help you when you inhale. Okay, they're one of the muscles involved in forced inhalation. Okay, and where would these muscles be? Well, you can see them. I'll kind of color them in here. Okay, so there's one. There's another one. There's another one. Okay, and so on. The internal intercostals have their origin on the superior border of each rib and insert on the inferior border of the adjacent superior rib, and they help to depress the ribs. Okay, so you can see one of the internal intercostals here. You can also pick up a few here, here, okay, and here, and here. Okay, intercostal literally means between the ribs. So this guy helps when you exhale forcefully. Abdominal muscles, okay, you got several of them. These are the external obliques here. You can see this is one of the most superficial muscles. So this is external oblique. And notice how the fibers run, okay? This muscle inserts onto this aponeurosis. The fibers run like this, okay? So I always remember this as hands in pockets. For the fiber direction. So that's your external oblique, okay? Origin, external and inferior borders of ribs 5 through 12, inserts onto the linea alba, which is this little midline tendon here, as well as the iliac crest. He compresses the abdomen, he depresses the ribs, and he flexes and bends the vertebral column. Underneath him, okay, are the internal obliques. Okay, and the internal obliques you can see here, and their fibers run at a right angle to the external oblique. Okay, so these are the internal obliques. These lie underneath the external. The origin is the lumbosacral fascia and the iliac crest, and the insertion is on the inferior ribs, the xiphoid process of the sternum, which is a little bump on the inferior aspect of the sternum, and also the linea alba. Right? And what does he do? Well, he compresses the abdomen, he depresses the ribs, and he flexes and bends the vertebral column. So he helps the external oblique do its job. Okay? The transverse abdominis is underneath him. You can see the fibers here running transverse to the long axis of the body. And the origins are cartilages from ribs 6 through 12, as well as the iliac crest and the lumbodorsal fascia. And the insertion is on the linea alba and the pubis. And what does he do? He compresses the abdomen. Okay, so all of these guys will help compress the abdominal contents. This helps you to urinate, defecate, and to forcefully exhale. And then finally, you've got the deepest muscle of all of these, which is the rectus abdominis, whose fibers run at a parallel orientation to the long axis of the body. You see there, okay. Origin is the superior surface of the pubis near the pubic symphysis, and inserts onto the inferior surface of the costal cartilages of ribs 5 through 7, as well as the xiphoid process of the sternum. And what does he do? He depresses the ribs and he flexes the vertebral column and compresses the abdomen. If you think of this muscle when you do your sit-ups, okay? Your sit-ups. Okay. Here you can see sort of an overview of the muscles of the thoracic and the abdominal pelvic region. They originate on the trunk. They control gross movements of the limbs. They're large and powerful. The posterior trunk muscles are mostly appendicular and originate on the large bones of the limb girdles and the proximal bones of the limbs. So again, we can kind of see these muscles as we outline them here. So let's use cyan for this. And we can start up top here. The sternocleidomastoid we've already addressed, right? He helps to flex the head down onto the chest, okay, and also helps to turn the head. There's the platysma, which we've talked about previously as well. He's superficial to the sternocleidomastoid. So again, this is the superficial side, see here, right? And this is the deep side. So the muscles on the right are underneath the muscles on the left. So the deltoid, all right, has his origin on the clavicle and the scapula and inserts onto the deltoid tuberosity of the humerus. So you can see him here. I'll outline him looking from the front. And what does he do? Well, he does a lot of things. He abducts, flexes, and extends, and medially and laterally rotates the arm at the shoulder. Okay. The pec major, you can see here, right? We sort of outlined him before. His origin is the rib cartilages from ribs 2 through 6, as well as the sternum and the clavicle. He inserts onto the crest of the tubercle and the lateral lip of the intertubercular groove of the humerus, which is basically the upper part of the humerus, the part that's nearest the shoulder. Okay, and what does he do? He flexes, adducts, and medially rotates the arm at the shoulder. Okay. Okay. Moving on to the other side, we have the deep muscles. Okay. And what do we see with the deep muscles? Well, when we look here, you can see that we have to cut away the deltoid, we have to cut away the pec major, and then underneath we can see the pectoralis minor, right? And we talked about the fact earlier that this guy is connected to the costal cartilages of the ribs and also to the scapula. Okay, so you can see him here. Okay, right there. So his insertion is on the coracoid process of the scapula, and his origin is ribs 3 through 5. And what does he do? He depresses and protracts the shoulder and rotates the scapula and elevates the ribs. Okay, I might have said earlier that it attaches to the acromion. No, it's the coracoid process of the scapula. I was mistaken earlier. Okay, moving down, the serratus anterior is known as the boxer's or the puncher's muscle, or the pitcher's muscle. You can see him here. Okay, he runs from the margins of ribs 1 through 5, and he inserts on the anterior surface of the vertebral border of the scapula, and he protracts the shoulder and rotates the scapula. Okay, so he helps with a pitching or a punching motion, essentially. Okay, so you could think of this guy as the boxer's muscle. This is one of the reasons why boxers have this muscle well developed, because they work on the punching bag a lot. Boxer's muscle. Okay. All right. Appendicular muscles. Large axial and appendicular muscles originate on the trunk, control gross movements of the limbs. They're large and powerful. For the posterior trunk, mostly appendicular origins on the long bones of the limbs and the proximal bones of the limbs. Okay, so what do we have here? We got several important muscles. Okay, and let's do these in yellow so they really show up nicely. The deltoid we've already talked about. Okay, that's the back of the deltoid here. Okay, that's all deltoid. This diamond shape, guys, is trapezius. Again, this is the superficial side here, and the deep side is on the right. Right? So this is the trapezius, huge muscle. Okay, huge muscle. Origin is the occipital bone and the nuchal ligament, which is basically dead center on the back of the skull, as well as the spinous processes of the thoracic vertebrae. He inserts onto the clavicle and the scapula, and he can elevate or rotate the scapula, elevate the clavicle, and extend the neck. Okay, very powerful muscle. Underneath him is the latissimus dorsi. Okay, so that's the latissimus dorsi here. Okay, all this, those are your lats. Origin is the spinous process of the lumbar and inferior thoracic vertebrae, as well as ribs 8 through 12 and the lumbosacral fascia. He inserts on the floor of the intertubercular groove of the humerus, and he extends, adducts, and medially rotates the arm at the shoulder. Okay, where do we see these muscles well developed? In swimmers. Okay, so let's right here for these two guys. Swimmers' muscles. What do swimmers do all day? They move water out from in front of them so they can move through the water. And these muscles help do it. This is one of the reasons why swimmers often have an upper body that has a very pronounced V shape to it. Okay. The gluteus medius, okay, is this muscle here. Okay, he runs underneath the gluteus maximus, which is this muscle. His origin is the iliac crest and the gluteal lines of the ilium. He inserts on the greater trochanter of the femur, which is basically the upper front part of the bone of your upper leg. Okay. And what does he do? He abducts and medially rotates the leg at the hip. Okay? Or, if the legs are still, he can abduct and medially rotate the trunk. Okay? The gluteus maximus is underneath him. This big muscle here helps to maintain our upright posture. So that's the maximus. Origin is the iliac crest, the ilium, the sacrum, the coccyx, and the lumbosacral fascia. And he inserts onto the iliotibial tract and the gluteal tuberosity of the femur, and essentially helps you extend and laterally rotate the leg at the hip. So this guy really helps you walk. Both of these muscles are important in maintaining bipedal posture. Bipedal posture, and also help you walk. Okay. Now, if we go to the other side, we have deeper muscles. Okay. The levator scapulae is this muscle right here, and as the name implies, he elevates the scapula. His origin is the transverse processes of the first 4 cervical vertebrae. He inserts onto the vertebral border of the scapula near the superior angle right here, okay, and he elevates the scapula. Underneath him are the rhomboid minor, which is this muscle right here, shaped like a rhombus, that's where it gets the name, and the rhomboid major right here. And what do these guys do? They help square your shoulder. The origin is the spinous processes of C7 through T5, and they insert on the vertebral border of the scapula. They adduct the scapula. Adduct the scapula. Okay? So that's basically bringing the scapula back towards midline. You can see some of the erector spinae, deep muscles that lie underneath the rhomboids and the lats. Okay? And down here, the external oblique that we've already discussed. Okay? So, important muscles. Here we get into the appendicular muscles. Okay? Proximal limb muscles are larger, longer, and stronger, fewer and less precise in their action than their distal limb counterparts. Proximal muscles are larger, stronger, fewer, and less precise than distal muscles. Muscles involved in extension of the elbow and the wrist are located on the posterior surface of the upper arm, while muscles involved in flexion of the elbow and the wrist are located on the anterior surface. The flexor and extensor retinacula hold the tendons of the muscles in place. Now, where is that? That's this little thing that looks like a wristband down here. Okay. So as we go through these muscles, we'll try it in blue again. So we start with the tricep brachii, this muscle here. Okay. Down here. So he's got 3 heads. Okay. One head runs from the superior lateral margin of the humerus, and one from the posterior surface of the humerus, and one runs from the scapula. So those are the 3 heads. Their insertion is on the olecranon of the ulna, basically the bump of your elbow. The action is extension of the elbow as well as extension and adduction of the arm at the shoulder. Okay. On the back side of the forearm, the extensor digitorum have their origin on the lateral epicondyle of the humerus. Okay, so we'll trace this muscle here, here, here. Lateral epicondyle of the humerus. And it inserts on the posterior surface of the phalanges. Okay, so those are the back of the fingers. All right, so where are we going to see that? There, 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 there. Okay. The action is extension at the finger joints and at the wrist. Over here, okay, the extensor carpi radialis, as the name implies, is going to be on the radial side of the forearm. Okay. So you can see this muscle here, here, okay. The origin is the lateral epicondyle of the humerus and inserts onto the base of the second and third metacarpals, which are the bones of the palms of your hands. So it's going to insert down here and here, okay. And what does he do? He extends and abducts the wrist, while the extensor carpi ulnaris, which is on the ulnar side of the forearm, here, here, okay, runs from the lateral epicondyle of the humerus, adjacent dorsal surface of the ulna, all the way to the base of the 5th metacarpal bone, which is going to be down here. Okay, and what does he do? He extends and adducts the wrist. Now, if you want to feel these muscles, stand in anatomical position, okay, and put your hand on the back of your forearm, all right, and then point your wrist backwards, okay, and you'll feel these muscles work, okay. You can do the same thing with your fingers, okay. You can feel that those same muscles work. Okay, there are also muscles that originate at the forearm and wrist and control movements of the thumb. Okay, those are extensor pollicis radialis, okay, or I'm sorry, extensor pollicis longus, extensor pollicis brevis, okay, and they help with movement of the thumb. Notice, okay, that the extensors are on the back of the forearm. We're going to find out that the flexors are on the front. So if we look here, we can see some of the flexors. Okay, so let's start with one of the most well-known muscles, the biceps brachii. We'll go with blue again. Biceps brachii is here. Okay, runs down to there. Has two heads, hence the term bicep. Okay. So what are the two heads? Well, one head runs from the coracoid process of the scapula and the other from a tubercle in the glenoid cavity, which is also on the scapula. Okay, so that's what we call the long head, and that's the short head. They insert on the tuberosity of the radius, okay, which is going to be, again, on the thumb side of the forearm. Okay, remember that the ulna is on the little finger side. And so what does he do? Okay, well, he flexes the forearm at the elbow, and he's engaged in supination, and he also can flex the arm at the shoulder. Okay, so two possible, because he passes across both the shoulder joint up here and the elbow joint down here. The brachialis is a muscle that's underneath the biceps brachii, and I'll just kind of color him in here and here. Okay, this is the brachialis muscle. You would have to lift up the biceps brachii to see him. Okay, his origin is the anterior distal surface of the humerus. He inserts onto the tuberosity of the ulna, so he crosses the elbow joint and he flexes the forearm at the elbow. The brachioradialis is this guy here, and he runs from the brachial region and inserts onto the radius, hence the name. Okay, his origin is the ridge superior to the lateral epicondyle of the humerus, and he inserts onto the lateral aspect of the styloid process of the radius, and he helps to flex the forearm at the elbow because he crosses the elbow joint. Down here, you've got the flexor digitorum muscles. Okay, so you can see those here. Okay, they have their origins on the medial epicondyle of the humerus and the surface of the ulna, and they insert onto the anterior surfaces of the phalanges, okay, which are, again, these are the metacarpals. These are the phalanges here and here. Okay, all right. And what do? They flex the fingers. Okay, flexor digitorum, as the name implies, flexes the fingers. Okay, all right. Tricep brachii we've discussed. You can see that muscle back there. Let's talk about some wrist flexors. The flexor carpi radialis, right? This muscle here, flexor carpi radialis. Okay, I'll kind of color him in as best I can. Runs from the medial epicondyle of the humerus to the base of the second and third metacarpal bones, and he flexes and abducts the wrist. The flexor carpi ulnaris, you can see here. Okay, right there. He runs from the medial epicondyle of the humerus and the olecranon of the ulna, and inserts onto the medial carpals and the first metacarpal bone, and he flexes and adducts the wrist. And then, in case you're wondering, this guy in the middle is called the palmaris longus. Okay, and he runs again from the medial epicondyle of the humerus, and he inserts onto the flexor retinaculum, and he helps to flex the wrist. Okay. Okay, this is the back of the lower leg, right? And again, we can do these. Let's try here. We'll do green. Okay. And we will start on the lateral side here. These are a group of very important muscles known as the hamstrings. Okay. So let's start with this is the lateral side, okay, of the leg. I'm sorry, of the thigh. This is the medial side. Okay? So, let's start with the most lateral muscle, okay? And that's the biceps femoris. So we'll trace him here. Okay? Biceps femoris. Two-headed muscle near the femur, hence the name. Okay? Origins the ischial tuberosity and inserts onto the proximal medial surface of the tibia, and he helps to flex the leg at the knee. Now when we mean the leg, we mean the lower leg. If we mean the upper leg, we would indicate the thigh. He's also important for extension of the thigh at the hip and medial rotation at the hip. Okay. Now, just medial to him is this muscle here, which is the semitendinosus. Remember, all these muscles are part of the hamstring group. These muscles help you bend your knee, among other things. Okay, semitendinosus. Origin, ischial tuberosity, inserts onto the proximal medial surface of the tibia. He flexes the leg at the knee and extends and medially rotates the thigh at the hip. Okay, and then underneath him is the semimembranosus. You can see a little bit of him here. Okay, and you can see a little bit of him here. Okay, semimembranosus. Okay, origin, ischial tuberosity. Insertion, posterior surface of the medial tibial condyle. He flexes the leg at the knee and he extends and medially rotates the thigh at the hip. Okay, and finally the sartorius muscle is a strap-like muscle on the inner thigh. You can barely see it right here. It's easier to see in medial view. And he has an origin on the anterior superior iliac spine and inserts onto the medial tibia, and he flexes the leg at the knee and also flexes the thigh and laterally rotates the thigh at the hip. Okay? So those are the muscles of the posterior thigh. Three of them, the biceps femoris, the semimembranosus, the semitendinosus, are your hamstrings. Okay, so let's star those so that we know. There's one, there's one, there's one. Okay, those are all hamstrings. Athletes injure these a lot. Why? Because a lot of times athletes will be running and stretching the leg out really far in front of them to get a ball, say, that's going out of bounds, and what will happen is that they will overextend the muscles in this group, and it feels like a hot knife going into the back of your thigh, and after that you're done for the day. Here's the front of the thigh. Okay, extensors of the knee originate on the femoral surface and are found on the anterior and lateral surface of the thigh. They include the quadriceps muscles, which are made up of the rectus femoris, the vastus lateralis, intermedius, and medialis. Okay, now let's go through each of these, the ones that we can, and let's try gray here. Okay, so some clues to help you remember these guys. This guy here is the sartorius muscle, okay, that I'm tracing. He's S-shaped, and he runs from the lateral thigh to the medial thigh, and he inserts onto the medial portion of the tibia. Okay, he helps you to cross your legs. Okay, this S-shaped muscle, the sartorius. Okay, these guys are adductor muscles, and what they help do is to bring the thigh back towards midline if the leg is, say, sticking out sideways at an angle to the long axis of the body. And they're made up of the adductor brevis, adductor longus, and adductor magnus, and a very, very tiny muscle called the pectineus. Okay, you don't need to know each individual muscle, just know that's where the adductors are. They're situated from the pubis to the medial side of the femur. Now to the muscles of the hamstring group. Okay, so we'll start with the muscles that you can see relatively easily. This is the rectus femoris. Okay, what I'm tracing here, rectus femoris. Okay, origin, anterior inferior iliac spine and the rim of the acetabulum. So he crosses the hip and he inserts where? Onto the tibial tuberosity via the patellar ligament. Okay, so he inserts right down here on this little bump, as do all the quad muscles. Okay, and what does he help you do? Extends the leg at the knee, so he helps you kick, and he also helps with flexion at the hip. So if you're standing up straight and you want to lift your thigh up while keeping your leg straight, he would help with that. He can also help with bending at the hip if you keep your legs straight under you. Okay, so those are two possible movements he can help with because he crosses both the knee and the hip joint. The vastus lateralis is this muscle here, a big muscle on the lateral side of the femur. Okay, he runs from the greater trochanter of the femur and the linea aspera, which is a ridge on the medial posterior side of the femur, and inserts onto the tibial tuberosity through the patellar ligament. Okay, so he only crosses one joint. He crosses the knee joint. And what does he help do? Extend the leg at the knee. Okay, and then the vastus medialis is this guy here. Okay, and he has his origin along the linea aspera of the femur and inserts on the tibial tuberosity via the patellar ligament, and he also helps to extend the leg at the knee because he only crosses the knee joint. Now underneath him, okay, underneath these three muscles, the rectus, the vastus, and the lateralis, right dead center is the vastus intermedius. So to see him, we would have to cut and reflect the rectus femoris back, okay, in order to see him. His origin is the superior surface, surface of the femur and the linea aspera, and he inserts on the tibial tuberosity through the patellar ligament. He helps to extend the leg at the knee. Okay, so those are your quads, sometimes abbreviated. Okay, so that's this guy. Okay, this guy, this guy, this guy. Where does it get the term quads? Because there's 4 muscles in the group. Okay. One more muscle we should touch on before we leave is the tensor fascia latae, sometimes abbreviated the TFL for short. He runs from the iliac crest and the anterior superior iliac spine, inserts onto the IT band, which runs all the way down here and inserts on the tibial tuberosity just underneath your kneecap. Okay, so he's a lateral muscle right here. And what does he help do? Well, he helps to flex and medially rotate the thigh at the hip. Okay, flex and medially rotate. All right, here we see the leg. And when we talk about the leg anatomically, we mean the lower leg. All right, so we got 2 views here. Again, we've got the superficial view on the left. Let's go back to blue now. So this is the superficial view. Okay, and we have the deep view on the right. All right, so what do we have here? We'll start with the gastrocnemius. The origin is the femoral condyles. So this is the gastrocnemius here. It's got 2 heads. And it inserts onto the Achilles tendon, which runs right down to the calcaneus, which is your heel bone. And this guy helps you point your toe and push off on your toe when you run. Okay, so that's the gastrocnemius. Okay. The soleus is underneath him. You can see a little bit of soleus here and here, and he also inserts onto the Achilles tendon, this guy here, the Achilles tendon. Okay, his origin is the head and the shaft of the fibula and the posterior-medial tibia, and he also helps you to point your toe. Okay, so what do we call pointing your toe? That's plantar flexion at the ankle. Okay, down here you've got the flexor digitorum longus. The origins are the posterior medial surface of the tibia and inserts onto the inferior surfaces of the distal phalanges, and he helps you to make a knuckle out of your toes. Okay, so you can see him here, okay, here, coming up. I'll color him in, maybe that'll help. Okay, so there we go. Okay, over here we have the fibularis longus right here. And there's a muscle superficial to him called the, or sorry, deep to him called the fibularis brevis. And what do? Well, they help to evert the foot at the ankle, so basically to flip the foot out this way. Okay, the origin for the longus is the lateral condyle of the tibia and the head and proximal fibula. Insertion is on the first metacarpal bone and medial cuneiform, which is one of the tarsal bones, and the action is to evert the foot and extend the foot at the ankle and support the foot's arch. Here we can see a lateral and a medial view of the lower leg. Oops, back up. Again, let's go with blue. Okay. Ankle extensors generate plantar flexion of the foot. Examples include the gastrocnemius and soleus. Muscles moving the toes are smaller and originate on the tibia, the fibula, or both. Superior and inferior retinacula hold tendons of muscles in place where they cross the ankle joint. Okay, so let's start with the tibialis anterior. Okay, see the tibialis anterior lateral view here. Okay, where's the tibialis anterior? Where if you feel for your shin, the bare part of your shin, the part lateral to that is the tib anterior. Okay, he runs from the lateral condyle and proximal shaft of the tibia and inserts on the base of the first metatarsal and medial cuneiform, and he flexes the foot at the ankle. So this is dorsiflexion, all right, which would be lifting the toes up, and he also can help in inversion of the foot. Okay, inversion of the foot is like when you turn your ankle. If you step into a hole and the sole of your foot points towards the medial aspect of your body. Okay, so that is the tibialis anterior, named because he runs in front of the tibia. Okay, there's also a tibialis posterior, in case you're wondering, and he lies deep to the soleus. Okay, more muscles. Okay, digital extensors. The extensor digitorum longus, you can see here, okay, here, okay. Origin, lateral condyle of the tibia, anterior fibula, inserts onto the phalanges of toes 2 through 5, and extends at the joints of toes 2 through 5, okay. So that would be like lifting your little toes up in the air with your sole of your foot planted on the ground. Okay, so it's right in there. It's a little tough to see. In fact, let me back up and back out. See if I can draw him a little bit better. Okay, he's right. Sorry, he's right here. There we go. Okay, right there. It's not a perfect trace, but basically right there. Okay. And you can also see the gastroc. You can see the soleus underneath. Okay. There's the fibularis longus. Okay. And underneath him, the fibularis brevis, you can see right there and there. Okay. They evert the foot at the ankle. And then this is from medial view. You can see the gastroc here, the soleus back here. And that essentially brings us to the end of the muscles of the appendicular skeleton. Okay. Now, there's a posting on the portal that tells you what muscles and what actions you need to know. Again, I've given you the origins and the insertions as well as the actions and the names. The reason I gave you the origins and insertions is to kind of help you with what the muscles do. You don't need to memorize those, but you do need to know the actions and the muscle names. Okay? So what I would do to help you with this is to go back and review your map of the body. Okay? Know, for instance, where the brachial region is, where the acromial region is, where the femoral region is, and so on. And that'll go a long way towards helping you identify these muscles as far as general location goes. Okay? Know your actions. Okay? The action of the muscle is sometimes in the muscle name, and you can guess what the muscle does based strictly on the name. An example would be the levator scapulae, which elevates the scapula. Okay? Just as one example. Okay, so that brings us to the end of this podcast. I'll see everybody in the next chapter, and I'll talk to you soon.